Good evening, everybody, and very warm welcome to our webinar this evening. It's great to see so many of you signed up to this. We'll just pause for a few moments to allow you all to join. Just bear with us. Okay. Good evening, and thank you for tuning in to our webinar this evening from Benenden Hospital on knee replacement surgery. My name's Phil, and I'll be your host for this session. And I'm joined by our expert speaker, Mr. Raman Thakur. And just to give you a brief overview of how the session will run, Mr. Thakur's presentation will last around 20 minutes. And following that, there will be a question and answer session. And you can submit questions any time during the presentation or after the presentation. And you can do this by using the Q&A icon at the bottom of your screen. And you can submit your questions anonymously, or you can give your name. And at this point, I should let you know that if you do give your name, we are recording this webinar. If you'd like to book a consultation, we'll be providing contact details at the end of the session. So without further ado, I will hand you over to Mr. Raman Thakur.
Thank you very much, Phil, for having me this afternoon. As mentioned, my name is Raman Thakur. I'm one of consultant orthopedic surgeon at Benenden Hospital. These are the points we're going to cover during the session. My experience, other consultant colleagues, what we do at Benenden Hospital, and talking a bit more about knees, osteoarthritis, knee replacement surgery, types, surgical process, the recovery process, and risks of surgery, and patient decision support tools, followed by time for question and answers. So I trained as an orthopedic surgeon from Hyderabad in India, and came over to UK and trained in the southeast of England and obtained my fellowship in trauma and orthopedics. Subsequently, I did a year's fellowship in New York, working at Lenox Hill and Hospital for Special Surgery for a year, specializing and expanding my skills in hip and knee reconstructions. I've been working as a consultant orthopedic surgeon based in Kent, and have worked at Benenden Hospital since 2012. I am a member of British Orthopedic and American Academy of Orthopedic Surgeons. Benenden Hospital is a leading provider of private hip and knee treatments in the region. It is a very pleasant atmosphere for working, and I'm sure for people who come here to have their treatments. It is have an experienced team of orthopedic consultants and physiotherapists who provide a good quality of care with high patient satisfaction rates. We are well engrossed and enrolled into the rapid recovery pathways of following hip and knee replacement. We have a team of colleagues and consultants who are doing and operating on both hip and knee replacements. Myself, along with another 7 of our colleagues, do provide both hip and knee replacements service. Benenden does over 400 knee replacements a year and about 500 hip replacements, and is still quite a competitor to Porter Center, which has been long established as a hip and knee replacement center in the regions, and ahead of the other private sector hospitals. Knee arthritis usually presents in the early phases as a early morning stiffness. First thing in the morning, when people wake up, the knee feels stiff. There is pain on activity, particularly gardening or long walks or running. And some patients may experience sensation of clicking or grinding and swelling of the knee. As the arthritis, the picture here shows what actually happens within arthritis, and my cursor is showing to the areas where there is denudation and damage to the covering articular cartilage, and gradually over a period of time then the bone gets exposed and then it becomes more advanced arthritis. And then patients experience pain at night, pain during rest. The knee starts getting a bit deformed, so it may either go inwards, causing knock knee, or the knee may go outward, causing a bow leg deformity. And walking distances significantly become reduced and become more and more intrusive level of symptoms and deteriorating function. The picture on the left shows a normal knee joint with good gap in the bone, and the picture on the right demonstrates more advanced arthritis with the complete narrowing of joint space, particularly on the outer or lateral aspect of the knee joint. What are our treatment options if patients are having an arthritic knee? Initially and early arthritic changes, treatment is non-surgical. First and foremost would be simple measures such as modifying some activities and avoiding some activities which may aggravate the condition if possible and acceptable. Weight management, if somebody is overweight, then having an arthritic knee and overweight increases pressure and accelerates the progression of arthritis in the knee. High BMI is a known predisposing factor for development of arthritis in the knees as well. So, but having already got arthritis, then certainly the progression will enhance, and therefore certainly weight loss would be a definite or beneficial and therapeutic value even for the longer term. Physiotherapy, any swelling that develops as a result of arthritis, gets any fluid in the knee, it will rapidly weaken and waste the muscles around the knee, and hence physiotherapy is an important measure to keep the muscles in good condition so that they support the joint and allow people to function. It will also help with pain relief and control of pain. Then going on to more intrusive measures, simple analgesics, paracetamol is a very good basic painkiller. And if paracetamol is not enough, usually people substitute and also add on non-steroidal anti-inflammatories. Sometimes people take the non-steroidals and stop the paracetamol. It usually is an additive effect. If either paracetamol or ibuprofen on their own are not helpful, sometimes adding them together may actually give more relief than just carrying on with ibuprofen or even stronger medication there. So more mechanical options are knee strapping or knee braces. They can give a bit of proprioceptive control, especially when people feel that the knee is giving way or feel unsteady, then certainly the brace can give a feeling of more security by adding on some proprioception from the surface of the joint. It is not something that one would want to get reliant on because it does affect the muscle bulk and muscle strength. So it is not something I would recommend people use it long term and get reliant on. Injections are another good adjuvants to help with the control of pain. Injections, either steroid injections or cortisone injections, or the other alternative type of injections are hyaluronic acid and lubricant injections, which we do at Benenden. Cortisone injections help with reducing the inflammation, helping with the reduction of swelling and pain, and is usually a normal hormone in the body. So one has to be careful in how many people can have over a period of time. And usual recommendation is not more than 2 or 3 a year, but also only if it has been working and giving good relief for a period of few months, then only it would be worth repeating. I tend to usually advise patients not to use them as a regular treatment, but to use them particularly for severe flare-ups or occasions when people are either having a special occasion like a wedding or a function which they need to get over, or a holiday to go through, then certainly having a steroid or a lubricant injection will certainly help them, enable them to do that. In the early phases, certainly hyaluronic acid can work and give people a much more prolonged relief of symptoms. But when it is bone on bone, unfortunately, the injections may not really last more than a week or two. So it also depends on how severe the arthritis is, in terms of how well the injection may provide relief to people. Then coming to the surgical treatment for osteoarthritis, starting with the simple ones, where there is deformity, one can correct the alignment with an osteotomy, basically cutting through the bone, realigning the bone and fixing it in that position, because then the weight gets transferred through the more natural part of the knee and allows the damaged area to heal itself. And therefore, there are people who have had good outcomes lasting over 10 to 15 years, and certainly would be something that would be recommended for the young patient. Arthroscopy, when the arthritis is not bone on bone, but less severe, and there are loose fragments or loose bodies in the joint which are catching, causing locking or giving way, or there is a significant meniscal tear, which is causing catching between the bones and causing further damage. All these, if there are mechanical symptoms, certainly an arthroscopy can help in that situation. Microfracture is a way of managing small bony defects less than 1 centimeter square. If it is bone on bone in that small area, sometimes we can make holes into the surface of the bone and allow bone marrow cells, which are pluripotent cells, and they can hopefully help reconstitute some cartilage-like surface and allow that knee to continue performing without recourse to a knee replacement surgery. Cartilage transplantation, unfortunately, has not been successful in osteoarthritis. It is more useful for localized traumatic defects in the surface of the joint and knee replacement surgery. We'll talk about that more in a bit. So it is a fairly common operation. Over 100,000 are performed in UK per year. And the average age where knees are replaced is between 68 and 70, but the range is anywhere from 55 to 85, 90. Over half of the patients who undergo knee replacement on the joint registry are 50 female patients, and 95% report significant health improvement and following recovery from knee replacement surgery. And they are also longevity in survival, and over 80% of these can last 25 years. So it is a reliable and durable solution for end-stage arthritis. Now, when a patient comes, we need to decide, is that the time, when is the time to have a knee replacement surgery? When realistically the quality of life is affected, the symptoms are quite significant and intrusive, affecting day-to-day or work, and also affecting at rest and night. It is with quite a considerable decline in function, then would be the time to consider knee replacement surgery. Obviously, the conditions in the background could be osteoarthritis, rheumatoid arthritis, or arthritis after severe trauma involving fractures on the joint surface or ligament damage. Why do we do knee replacement? Idea is to get relief of pain. Over 85% of people are pleased and happy with the outcome of surgery, and over 90% find that the knee replacement has been beneficial, though not completely relieve their pain. So pain relief is one of the most important indication, pain, and that would be our primary reason to consider knee replacement surgery. Obviously, along with relief of pain will come improvement of mobility, restoration of other ability to do other functional uses. Half of my patients can kneel, half of my patients cannot kneel. So there can be a bit more normalcy restored to some or more of the patients. And at the same time as we are doing the knee replacement, we also aim to correct the deformity and in most people we have managed to get that correct out straight. Younger patients have higher functional demands, both with work, sports, and have greater expectations. The success rates of knee replacements has got a definite distinction around the cutoff age of 55. Less than 55 has much less success rates shown in literature compared to people over the age of 55. What are the options when we come to discussing knee replacement? That really depends on what or how much damage has happened within the knee. If the arthritis is localized to one part of the knee, then one could consider replacing only that compartment. It is called a unicompartmental. It could be either the medial, which is on the inside, the lateral, which is the outside, or the kneecap joint, which is the patellofemoral joint replacement, which is the joint between the kneecap and the front of the femur. A total knee replacement involves taking the cruciate ligaments out and replacing all the three joint surfaces. The kneecap itself may or may not be replaced depending on the damage. There are some surgeons who will never replace. There are some surgeons who will routinely replace, and I usually base it on the level of damage on the surface of the burn. So if the burn is reasonably good, I would tend to leave it, because there are also complications associated with doing a replacement on the kneecap. So knee replacements, total knee replacements can be done through the conventional standard instrumentation, which is over 90% of knee replacements done in the country. Computer navigation has been up and down. We have used them regularly in the past. Now people have gone away from them because there hasn't been a huge difference, but we do still use them when people have got either metalwork in the bones of femur and tibia, or indeed they have got a deformity from a previous injury that maybe preclude us to putting rods up so that we can do the knee replacement. So there is still a role in a specific group of patients for computer navigation. Robotic surgery is taking a much more prominent role. It is coming in possibly to Benenden late next year, or spring of next year, and hopefully there are some exciting times ahead for us. Again, the purpose of using these tools is to give a more reliable positioning of the prosthesis. Ultimately, it doesn't always necessarily equate to getting the best outcome out of knee replacements, but we can at least ensure that technically we do as good a job as possible. If the ligaments are and soft tissue envelope is damaged, then there may be a more bigger knee replacement surgery called constrained knee replacement. Basically, what it means is that we are trying to substitute for the absent ligaments. So if people have got a medial collateral ligament or a lateral collateral ligament insufficiency, then, and even when we are doing a posterior cruciate. So there are levels of constraint which are introduced, and when subsequently revision surgery or severe deformity, we may have to use a prosthesis which has got more constraint so that it also substitutes for the damaged soft tissue envelope. The most common prosthesis we use at Benenden is the Vanguard prosthesis, which is made by Zimmer Biomet. It has an ODEP rating of 15A, and the 10-year survivorship is over 96%. It is one of the top 3 companies, and we use the prosthesis as a cemented prosthesis. I use bone cement to hold the prosthesis in position. And as I mentioned earlier, with or without resurfacing the patella, depending on the severity of wear. And in a knee replacement surgery, the diseased joint surface, we resect the diseased bone and shape the bone to fit the inner aspect of the prosthesis. So then it will fit like a cap on the front and a table on the top with a plastic spacer in between. Following the knee replacement surgery, hospital stay is usually 2 to 3 days. And initially, when patients come back from theater, they have the knee wrapped in a large protective dressing, which is taken down at 24 hours to leave the inner sterile dressing on. Pain is managed with medication. Important to understand that it is a painful operation, and people will be talking to you and asking you, nurses, physiotherapists, and doctors will be asking regularly, are you in pain? And because we are expecting that you will be in pain, and we want you to ask for painkillers so that you control the pain, and then you can do the exercises so that you will get a good benefit of the and a successful outcome from the procedure. You have daily visits from the physiotherapists on the ward, and they go through the exercises, and we'll also tell you about exercises, how to get about at home, and how to carry on. Background and essential to our care is the highly skilled team of nurses on the ward who are very experienced and look after all your needs. Your patients go home when it is safe to do so, and the main things that we expect are that patients are independently mobile with either a frame or crutches, have done safely up and down stairs, and we are happy that the wound is clean and dry. And after about a week, most people can walk with sticks if the pain levels and swelling permits. Subsequent recovery over the 2-week period, it is still quite a painful thing. The bruising will appear and sometimes can be quite dramatic, extending from all the way from the hip to the knee and sometimes down to the ankle. Some of my colleagues use staples, and they may need to come out at 2 weeks, and exercises is an important part of the recovery. It is essential that people take the painkillers and do the exercises. Most patients find that the initial month is quite a difficult experience, but usually by 6 weeks, their pain is improved significantly compared to even before the operation, and they can walk both at home and outside, and at 6 weeks, if one is safe to drive, then they can start driving. On a general basis, what I say is, if you are sitting comfortably for half an hour, or your sitting tolerance is an hour, you can possibly drive for half an hour. So it is roughly about half your sitting tolerance that is the distance you can start driving. If you're planning for longer distance driving, then you probably need to also incorporate regular breaks into your driving schedule. Follow-up appointment is at 6 weeks' time for most of our surgeons. At 3 months, over 90% of recovery has happened, and people feel more reliable benefit of surgery and start returning to normal activity. Usually any work-related cessation of activity, we say, and return back to work at 3 months post-surgery for most of the office and desk-based activities. If somebody is doing more strenuous activities, it may be the start of a phased return to work. And continue following advice and exercises as appropriate for full recovery. Full recovery may take all the way up to a year, and the swelling following a knee replacement can be there from anywhere up to 6 months to a year. So don't get alarmed that, oh, my knee is still swollen, my leg is still swollen. Most important is that swelling better than a previous week or previous 2 weeks? And that really is your gauge of recovery, that things are getting better. Risks after knee replacement divided into 3 phases. Early during surgery, obviously bleeding, and if the hemoglobin drops quite low, then may need a blood transfusion. Injury to the tissues, all the clockwork is around, the nerves, the blood vessels, the tendon, the bone, they are all at risk, and we take precautions to limit damage. During the recovery phase, we are concerned about ongoing oozing, bleeding from the wound. We do give blood thinners to reduce risk of blood clots in the leg. and that can cause ongoing oozing and bleeding and bruising around the knee. So if that is happening, it is important to let us know, and sometimes to stop the blood thinners for a day or two on the advice of the doctors to ensure that the wound becomes dry. Infection, if the wound continues to leak, then it could lead to infection and may need antibiotics. Occasionally, we may want to go back in sooner rather than later to wash the knee out. Blood clots in the leg, DVT, and blood clots can migrate to the lungs despite us giving blood thinners. And if the swelling is persistent and not settling, then may need a visit to A&E to have a scan and exclude a blood clot. And in the late stages, infection, long-term chronic infection can happen, and implants can fail because they can come loose or wear out and may require revision surgery. A fracture may happen because of an accident, and if it involves the prosthetic area, then it will again require revision surgery. Dislocation is less of a common problem with knee replacements compared to hip replacements, which is much more common. There are some patient decision support tools, certainly on the NJR, which is the National Joint Register. On that website, there are information regarding your surgeon's profile, the hospital profile, how patients have rated it. There is also private healthcare independent network. These are all the areas, places you can go and get more information for your due diligence. And certainly whether you as an individual can benefit from a knee replacement or a hip replacement, and whether it is, what are your risks as an individualized calculation. If you want to do that, you can certainly use the patient decision support tool on the NJR website. All right, Phil, over to you.
Thank you. Some informative points on the treatment options and the patient journey there at Benenden. And we can now start to take some questions from our attendees. So this person asks, I am very nervous of having a total knee replacement as I'm in my 50s. I know it's possible that I may need another replacement in my lifetime. Is it still as effective the second time?
The first and foremost thing, and I think you're right to be nervous about it in the 50s, I would be too. It is more important is it the right thing for you? That would be my first question. And certainly failure of the prosthesis over time and need for revision surgery is certainly high on the agenda. Yes, it can be redone. It is not a problem. But I think getting that decision right the first time and seeing if other things can help keep you going until you have to have your knee replaced is certainly my recommendation and advice, if possible, to keep going as long as you can. Obviously, it may be that the arthritis is so bad that that is the only alternative and option available. So it certainly would be worth getting yourself checked by an orthopedic surgeon and getting that advice.
Okay, thank you. This attendee asks, this may sound odd, but once recovered, will I be able to do things such as jump or kneel? I often look after my grandchildren.
So it is interesting. Patients ask me this, and I tend to use the analogy of a Rolls Royce. If you buy a Rolls Royce and drive it off the road, do you think it will last? So having said that, if you are going to do an occasional run, if you need to run for a bus or run for the train, otherwise you're going to miss it, go for it. if you're recovered and you're doing it. But on a regular basis, as a regular form of exercise, people doing running, people doing marathon runs, people have done it and they still do it, but that is not the recommendation that would be from my mouth, certainly. That is not something I would recommend.
Okay. This person asks, can statins have a major effect on knee joint pain? I also appear to have muscle wastage on the same leg as the painful knee.
So muscle wastage is a common side effect of having a painful um, limb, mainly because if you have particularly say arthritis, in general also if you had an accident or something and you have had an injury, the muscles tend to waste rapidly because you have not used it. Even if you spend 2 or 3 days in a bed, you'll notice that there is a rapid wastage of muscle because we are not using that as commonly or as regularly. So that in itself is an important thing. And particularly if you're getting any swelling and fluid on the knee, then muscle wastage is a common essential thing. And that's the reason why it is sensible to keep exercising within the limits and constraints and comfort, or finding alternative ways of exercising so that you keep your muscle condition in the leg. What was the other part of the question, Phil?
I think he asked about statins.
Yeah. So,
Um, hmm,
are known to increase musculoskeletal pain, and people do get myalgias, arthralgias, and sometimes so pain in the muscles, pain in the joints, and pain in the tissues. It is very individualistic, and one needs to assess on an individual basis because you need to weigh the benefits versus the side effects. It is a known side effect, but if it is really bad, then you need to discuss with your doctor whether you need to discontinue.
okay, thanks. We've seen this question, I think, on previous webinars. What gap do you recommend between first and second knee replacement?
So usually we don't tend to do bilateral knee replacements at Benenden, and we usually tend to stage them. And what happens is, in practical terms, the first knee is done. You come to see us 6 weeks after the surgery, and at 6 weeks, if you are doing well, you want to go ahead with the other side, then we can list you for surgery, which will be probably another 6 to 8 weeks. So usually by 3 months is the minimum we say to give the gap. And that is the minimum. It doesn't mean you should have it at 3 months. You can have it any time afterwards, depending on your own convenience and comfort and your tolerance.
Thank you. This lady asks, what types of sedation do you offer?
No, the reason I laugh is because this is what I tell my patients, and everybody has a laugh, but it is a webinar, and I am aware that there are quite a few number of people, and I just don't want to alarm people. So you have an anesthetist looking after you. That is the most important message I want to give out, because as a surgeon, I'm doing the actual procedure. I'm not looking after you during the surgery. So the anesthetist is a person who will decide what is the best form of anesthetic for you. Having said that, over 95 or 90% of my patients have a spinal anesthetic and something to keep you in the fairyland under sedation. And I usually say and quote, like Michael Jackson, and I'm just trying to say, for that particular reason, that you have a specialist who actually looks after you and titrates that medication, and you don't have a cardiologist looking after you. So that was the reason for my laughing earlier.
This person asks, is there a BMI limit to being able to have surgery?
So the upper BMI limit for having surgery at Benenden Hospital, joint replacement, either hip or knee, is 40. Certainly, if I see anybody over that, I would encourage you to certainly work and get your weight down. It is a achievable target for most people, and it will certainly make the surgery safer and reduce the risk of complications, and enable us to put the prosthesis in the best position and give you a better outcome, hopefully, from surgery. So certainly, I would encourage people to get their BMI below 40. If you do need help, you can see your doctor, you can get to support groups, or also some of our bariatric colleagues actually offer some medical treatments as well as surgical treatments. So you've got all those options of taking and seeking help for weight management.
Okay, thank you. This person asks, what should I be doing to prepare for surgery? For example, exercises.
First and foremost, you need to get your diagnosis confirmed. You need to find that the arthritis is severe enough and you do need the surgery. And if that has been agreed with the surgeon, then certainly keeping your muscles in good condition, keeping active, which whilst you're waiting for knee replacement, is very essential. Upper body strength, working on it is important. Coming near, asking the right questions of the team, making sure you're aware what is required from you, making sure that you are clear of any infections, because any health issues, all these can hamper your recovery and increase risk of complications. And certainly having an infection increases the likelihood that your surgery might be canceled on the day. So if you've got any concern with water or chest infection or anything, get that promptly checked by your doctor, get that cleared. Find out what things you need to bring to hospital, speak to the team about what are the arrangements for physiotherapy, what are the arrangements for your going home, and the process which we did discuss how we at Benenden manage. So similar thing, finding out what is who will arrange the physiotherapy, how it will be arranged, who needs to organize the physiotherapy after surgery. All those things will be important considerations around, before, and during your recovery from surgery.
Thanks. The next question is, I still have good joint space, but suffer with patellofemoral osteoarthritis. Is a total knee replacement still the best option? I'm 64 years old.
So I am one of the surgeons who would offer partial knee replacements. And if someone has got a problem only in one part of the joint, then I'm more than happy to offer you, if that's the case, a patellofemoral joint replacement. But it needs to be properly assessed. It needs to be made sure that the rest of the knee is completely okay, and that your symptoms and signs justify us going down that route of surgery.
Thank you. This person asks, I don't have pain at night or sitting and walking in general, but my walking now is limited to about 4 miles after previously being a good walker. My x-ray shows that there's not much cushioning left. Should I leave my replacement until I'm in more pain? I'm 79 years old.
I think that most people on this call will say 4 miles is very good level of activity that you're able to manage. And personally, if I were able to do that, I would try and keep going with whatever options. As I said, if you haven't come to bone on bone, maybe you can have those treatments like the hyaluronic acid or something to keep you going for a while until your mobility gets slightly more worse and you're getting more intrusive symptoms in other aspects of your life, um, like stairs, slopes, things like that, or day-to-day activities. That becomes then a more important feature than certainly a knee replacement would be on the cards.
Okay, thank you. This person asks, is swimming recommended when suffering with knee issues?
Yes, it is a good exercise. The only thing that I would say with swimming is to avoid the breaststroke leg movement because that is particularly not helpful with arthritis. But if you can do the um, um, backstroke or front crawl flat movements with your legs, then certainly that is a very beneficial exercise to help strengthen your knee and keep you going, and also a general exercise for your fitness. Um, some people can't do that. They just walk in the water. Again, walking in the water, doing a bit of aqua aerobics, any of those things can help keep your muscles around the knee in good shape, as well as help with general health fitness.
Okay, thank you. This person says, I've had an injection of Benenden today as I have advanced arthritis in one knee. I'm hoping that this will help in the short term and delay the need for a knee replacement. At what age should I ideally wait to have a replacement to maximize the benefit? And she adds, she's 58.
Yeah. So um, if you have advanced arthritis, obviously the surgeon felt that you are probably a bit too good or a bit young to, or with your profile in terms of your activity and your work requirements, that knee replacement may not be the right thing straight away for you. But if you find that you're getting only benefit for 2-3 weeks and then the pain is coming back, then injections may not be the right answer for you. And whether or not other interventions such as arthroscopy is appropriate, again, if it is bone on bone situation, then that may not be appropriate. So I think it is a bit difficult to individualize on your management, but certainly trying the non-operative measures would certainly be a good thing. And if they work for you, that is brilliant and may allow you to get another couple of years. Now, we did talk about the long-term survivorship and things. So even if we do surgery in the early 60s, there is always a possibility that you may need a one further operation, hopefully around the 80-85 years situation. But not everybody who does have a joint survived until then requires a revision. So keep our fingers crossed. It may last you long, but yeah, I would say hold off for as long as you can. And if you can't hold off, then you need it, you need it.
Okay. Next question is, I have issues with opioid and codeine pain relief. What are the other options that could be available for me? I'm
So-
61 and I have chronic pain issues and my mobility is poor.
Sorry, Phil, you were breaking up in there. Can you repeat just a bit?
Apologies, I'll repeat the question. I have issues with opioid and codeine pain relief. What are the other options that could be available to me? I'm 61 and I have chronic pain issues and my mobility is poor.
Right. So I think what you're describing is a slightly complex situation. And if you are unable to tolerate the simple codeine and slightly more stronger opioids, which your doctor has tried, and when you say chronic pain, it may not be just your knee, there may be other areas that are affected. So have you been or referred to, or have you ever had um, uh, consultation with a chronic pain consultant? Because they would be the ones who would be the appropriate people to advise you on various options, both from straight from a mechanical, from electrical, from simple heat, cold options, acupunctures, or indeed medical management of pain and discussing of the various pain pathways. So I would certainly, if your pain is not controlled and it is significantly affecting your quality of life, then certainly a chronic pain consultant would be certainly the person to go and see.
Okay, thank you. I think we have two people asking the same question here. Is there an upper age limit for knee replacement surgery? And one of these people says, I'm 76 and in good health, and I've lived with osteoarthritis of the knees for 25 years.
So honestly, there is no upper limit for doing any replacement. My oldest patient was 90. And my oldest hip replacement patient was 95 for osteoarthritis. I have done hip replacement in an 98-year-old who was perfectly fit after a broken hip. So I think the important determinant features are what is your quality of life, and two, the health status. So if you are in good health and your general quality of life is pretty good, and it's just the joint which is affecting you, then I think you should consider having the joint replaced. And 76 is certainly the most common age for us doing knee replacement.
Thanks. This attendee asks, you mentioned the Vanguard prosthesis had a 10-year survivorship. How does this relate to a knee replacement lasting 25 years on average? Please, could you clarify?
So what we are saying is, in general, the failure rate of knee replacement long term is 1 in 100 per year. So at 10 years, if we did 100 today, 10 would fail. 20 years, 20 would fail. 25 years, 25 would fail, that sort of thing. So they fail over a period of time, and they fail generally at that sort of rate. Occasionally, it may be one or two more, three or four less, but that is the sort of average over a period of time. And that is what we were talking about. So when we said 10 years, there is less than 10% failure rate. It might be slightly higher later on, or it may continue at that, because the important things to understand is that the plastic which was used for knee replacement surgery, that has certainly become much more developed, enhanced, and we are using high quality, high density polyethylene, which used to fail much earlier in older prostheses. So when you're looking back in time, you're not judging the same materials over a period of time. So whilst things have failed earlier in the past, the duration and survival seems to be getting better with the newer materials.
Okay, thank you. I'm afraid we've run out of time to take any further questions, and I apologise to anyone who didn't receive an answer to their question. But if you've provided your name, we can answer your question via email. Raman, please could you move to the last slide if you could?
Thank you very much, everyone. Hope you found that very helpful.
Just to add, as a thank you for joining the session, listed on this screen, as you can see, we're offering the value of your consultation refunded upon your booking, a callback from your dedicated private patient advisor, and you'll receive an email tomorrow with a recording of this session and some further information, plus updates on news and future events. If you would like to discuss or book your consultation, our private patients team can take your call until 8:30 p.m. tonight, or between 8 a.m. and 6 p.m. Monday to Friday, using the number on your screen now. And we'd be grateful if you could complete the survey when this session closes to improve our future events with your feedback. Our next webinar is on prostate enlargement, and you can visit our website to sign up for that. All that remains for me to say is, on behalf of Mr. Thakur and our expert team at Benenden Hospital here, I'd like to say thank you for joining us today, and we hope to hear from you very soon. Thank you and goodbye.